So, I want you to imagine you're looking at this massive, incredibly detailed global map of mental illness.
Right, like a giant satellite image.
Exactly. And every single diagnosed case of, depression, anxiety, schizophrenia, they're all represented by a little pin on this map.
That would be a lot of pins.
A staggering amount. But now imagine that with just a quick flick of a pen, you instantly wipe out roughly 1/3 of all those pins.
Just gone.
Yeah, a full third of the global psychiatric cases just completely erased in a matter of seconds.
Well, I mean, it sounds like an impossible medical miracle, doesn't it?
Right, like we cured it overnight.
But that is not what happened.
Yeah.
That massive drop wasn't the result of some groundbreaking new drug or, a sudden shift in human biology.
Though it's much simpler than that.
Yeah, it happened because researchers simply tweaked a few words in how they defined a case.
Just a few words.
Literally. They added a requirement for clinical significance, meaning the symptoms had to actually impair the person's daily life.
And just like that, millions of people who previously met the criteria for a disorder were just, reclassified.
Right. They were wiped off the map.
And that staggering fact is really the perfect gateway into what we're tackling today on this deep dive.
Because we are stepping out of the individual clinic today. We're taking a massive step back.
We are. If you're a clinical psychiatrist, your focus is naturally drawn to a single, highly complex tree right in front of you.
You're looking at its leaves, the bark.
Exactly. The unique way its roots have had to, twist and navigate around the rocks and the soil. You're looking at its individual, deeply personal struggles.
But epidemiology is the satellite view. It steps back, way up into the atmosphere, to look at the entire forest.
Right.
It asks how many of these trees are thriving. Where exactly are the blights spreading?
What are the overarching environmental factors, right? Like the quality of the soil or the shifting weather patterns?
Spot on. It's looking at how the surrounding flora is shaping the health of the entire ecosystem.
So today, we're taking a deep dive into psychiatric epidemiology. And we're using the foundational framework from Kaplan and Sadok's comprehensive textbook of psychiatry as our structural spine.
It's a brilliant chapter.
It really is. And to grasp the magnitude of this, we need to explicitly anchor ourselves to a core philosophy for this whole deep dive.
Which is that psychiatry is the study of how brain, mind, and experience interact.
Yes, and crucially, how that complex process can go wrong.
And you have to remember that interaction doesn't happen in a vacuum. It happens within populations.
Across different demographics.
Exactly. And it's influenced by a myriad of external pressures. In clinical practice, you are rightfully invested in the narrative of the person sitting across from you.
The single tree.
Right. But when you adopt the epidemiological lens, you're looking for the hidden patterns.
Structural forces.
Yeah, the statistical realities that dictate why that person, and, thousands of others like them, ended up in your consultation room in the first place.
Now, when most people hear the word epidemiology, I think they instantly picture infectious diseases.
Oh, absolutely. Tracking patient zero in a viral outbreak.
Right, or mapping the spread of cholera from a specific water pump in London, Broad Street pump. Right.
The classic Jon Snow example, yeah. But psychiatric epidemiology is a different beast entirely.
How so?
Well, we aren't tracking a highly contagious virus that spikes and disappears in a matter of weeks. We're dealing with conditions that rarely follow that acute, explosive pattern.
Right, they're much more drawn out.
Exactly. Psychiatric disorders typically follow a chronic, relapsing, and remitting course.
So the maths has to be different.
Completely different. The analytical models we use in this field look much more like the models used to study chronic illnesses.
Like what? Cardiovascular disease.
Cardiovascular disease, diabetes, oncology. We are looking at long-term trajectories, sustained risk factors, and lifetime prevalence.
That makes sense, because if you're tracking something like major depressive disorder, you aren't looking at a sudden transmission in a crowded room.
No, not at all.
You're looking at genetic predispositions interacting with decades of environmental stressors.
Precisely. And to really map out how we study this, the foundational literature often points back to a framework from the 1950s.
Right, by a researcher named Stuart L. Morris.
Yes, Morris. He outlined the core uses of epidemiology, and it's quite remarkable how perfectly his concepts still govern modern psychiatric research today.
We don't need to list them all off like a textbook, obviously. But his first major theme was this idea of historical study.
Tracking demographic shifts over time, which I have to say is incredibly challenging in psychiatry.
Why is it so hard?
Well, if you try to track rates of a specific disorder from, say, 1950 to 2020, you run into a massive roadblock. Our diagnostic customs have changed so radically.
Oh, right, the definition shift.
Drastically. What a psychiatrist in 1960 called neurosis might be split into 5 different anxiety disorders today.
So comparing historical rates of specific diagnoses is essentially comparing apples to oranges.
It really is. But we can still track the impact of shifting population demographics.
Like the sheer number of people entering different age brackets.
Exactly. That's where historical epidemiology shines. The classic example here is the aging of the baby boomer cohort.
Because there's this massive, unprecedented demographic bulge moving into their later years right now.
Right. And knowing that age is the primary risk factor for major neurocognitive disorders, like Alzheimer's disease, well, the epidemiological models project a staggering increase in prevalence over the coming decades.
So just to be clear, it's not that the disease itself is becoming more virulent or contagious?
No, not at all. It's simply that the population of susceptible individuals is swelling.
Wow. And that data is what allows governments and healthcare systems to actually anticipate the future public health burden.
Exactly. It tells us, we need to train more geriatric psychiatrists and build more specialized care facilities right now.
Before the wave crests.
Spot on, before it's too late.
That flows really nicely into another of Morris's core things, which is community diagnosis and mapping health services utilization.
Which is really about calculating the actual societal burden of an illness.
Right, we aren't just counting people who are sick. We're trying to figure out who is actually getting help and where they are getting it.
And this reveals a fascinating reality about what is often called the de facto mental health service system.
Unpack that term for me, de facto mental health system.
Well, when you ask someone to picture mental health treatment, they almost always picture a traditional specialty setting.
Like a psychiatric hospital or a therapist's private clinic.
Exactly. But decades of epidemiological surveys have proven that this is a massive misconception. The bulk of mental health care does not happen there.
Where does it happen then?
Primarily in general medical settings. The primary care physician, the local GP, is actually the frontline psychiatrist for the vast majority of the population.
Wait, really? The local GP?
Yes. A massive portion of mental health care also happens in social service agencies, schools, and even through alternative medicine providers.
So it's much more diffuse than we think.
Hugely. Globally, the primary care setting is a heavily utilized, critically important source of psychiatric intervention. Most antidepressants, for example, are prescribed by GPs, not psychiatrists.
That really underscores why a general practitioner needs to be razor sharp on psychiatric diagnosis.
They are the ultimate gatekeepers.
They really are. But this brings up a major philosophical and epidemiological hurdle, right? Defining what actually constitutes a treatment need.
Oh, it's a massive debate.
Because if an orthopedic surgeon sees a compound fracture of the femur on an X-ray, the treatment need is intrinsic. It's binary. It's undeniable. You fix the bone.
Right. But in psychiatry, it's rarely that clear-cut.
Because the symptoms exist on a continuum.
Exactly. Psychiatric symptoms frequently exist on a continuum with normal human mood and emotional states. Sadness, anxiety, grief, transient sleep disturbances.
These are just universal human experiences.
They are. The distinction between a normal reaction to adversity and a clinical disorder relies heavily on features like duration, frequency, intensity.
And appropriateness to the context, I imagine.
Yes, exactly.
Yeah.
So the diagnostic threshold, the line distinguishing a typical human reaction from a pathological one, is inherently fuzzy.
It's not a broken bone.
No, it's not. And it often comes down to the degree of functional impairment the individual is experiencing.
Like, is this sadness preventing them from getting out of bed?
Or maintaining their job or caring for their children. Furthermore, you have to consider people who might not meet the rigid criteria for a formal DSM diagnosis, right?
But they're still suffering.
Exactly. They still experience profound, debilitating distress that requires clinical intervention.
So because of this continuum, defining exact treatment needs at a population level must be incredibly difficult.
It's a tightrope walk. You risk either pathologizing normal human struggles,
which nobody wants.
Right. Or, on the other hand, denying care to people who are genuinely suffering but fall, one symptom short of an arbitrary cutoff.
It's a really delicate balancing act. But if we want to really understand the natural history of a disorder, we have to look at the whole picture.
How it starts, how it progresses, who is most at risk.
Right. And this brings us to a a massive fundamental pitfall in medical research. I've actually got an analogy for this one.
I'll go for it.
Okay, imagine you're tasked with writing a comprehensive review of a popular local restaurant.
Okay, a restaurant review.
But the only people you are allowed to interview for your article are folks who got severe food poisoning there and ended up in the A&E.
Right, the emergency department.
Yeah.
Well, your view of that restaurant is going to be incredibly skewed.
Completely warped. You'd write an article concluding that eating at this establishment is basically a near-death experience.
Characterized by violent illness and hospitalization.
Exactly. You would completely miss the thousands of people who had a lovely, uneventful meal and went home happy.
That is a brilliant way to conceptualize Bergson's bias.
Bergson's bias.
Yes, and this is an absolutely vital concept for clinicians to internalize. If you only study a psychiatric disorder by looking at the patients who show up in hospitals or specialist clinics.
You're just looking at the food poisoning victims.
Exactly. You are looking at a heavily biased, unrepresentative sample.
But wait, why are they unrepresented? I mean, they still have the disorder, right?
They do. But people who seek out and actually receive specialized treatment are systematically different from those who don't.
In what way?
Hospitalized patients typically have much more severe manifestations of the disorder. They usually have a longer duration of illness.
That makes sense.
And crucially, they have a much higher rate of comorbid conditions,
Mm.
meaning they suffer from multiple disorders simultaneously.
Like severe depression paired with a substance use disorder.
Exactly. Plus, there are massive socioeconomic filters at play here.
Oh, right. Who has the health insurance or the financial resources or even just the geographical proximity to access a specialist clinic in the first place?
Precisely. So clinical samples differ drastically from community samples.
Oh.
Bergson's bias specifically describes the erroneous conclusions you might draw about risk factors or the natural severity of a disorder.
Just because hospitalized patients naturally have higher rates of comorbidity and severity.
Right. If you base your entire understanding of schizophrenia only on patients in secure inpatient wards, you'll think it's uniformly devastating.
And entirely resistant to treatment.
Yes. Completely missing the individuals living relatively stable, functional lives out in the community.
You cannot understand the forest if you only study the trees that have been struck by lightning.
I like that. That's exactly right.
So to complete the clinical picture accurately, epidemiologists have to conduct vast, expensive, community-based surveys.
To capture the people who have the disorder but never cross the threshold of a clinic.
And when we do those community surveys, we often use the data to identify syndromes and assess individual risks, right?
Yes, we're looking for patterns to figure out what constitutes a normal variation of human behavior versus an actual disorder.
Give me an example of that.
Well, for instance, if epidemiological research reveals that a particular cluster of symptoms is highly prevalent in the community.
Lots of people have it.
Right. But it causes almost no associated disability, distress, or increased mortality. We have to ask ourselves, is this a disease or is it just a normal variant of the human condition?
On the flip side, we're also trying to assess risk. I mean, in general medicine, this is well established. High cholesterol, hypertension, a pack-a-day smoking habit.
They exponentially increase your risk of a myocardial infarction.
Right. Epidemiology gave us those risk profiles for heart attacks. Are we doing the same thing in psychiatry?
We are certainly striving to. By identifying specific risk factors, whether they are genetic, environmental, or social, we can theoretically develop individual-level preventive interventions. Right, because our understanding of psychiatric risk is constantly evolving, translating population-level risk factors into actionable, preventative clinical interventions for a single individual in your office.
It's a lot harder than prescribing a statin.
It is still in its nascent stages compared to cardiology or oncology.
Which naturally leads us to the holy grail of epidemiology, which is identifying causes. We're trying to move beyond just noting that two things are associated to actually understanding the underlying etiology.
Because if we know the cause, we can develop targeted curative treatments.
But causation in psychiatry is never a straight line, is it?
Almost never. It's incredibly complex because psychiatric etiology is virtually always multifactorial.
Right.
You rarely have a single pathogen like the tuberculosis bacterium causing a single predictable disease. It's an interplay of genetic vulnerabilities, environmental exposures, and psychological stressors.
Let's talk about those gene-environment interactions. There's a famous example in the textbook regarding the serotonin transporter gene.
Yes, a classic study.
And let's get into the weeds here a bit, because the terminology in the source material can be quite dense. The textbook notes an association involving a, quote, polymorphism in the promoter region of this gene.
Right.
Stop right there. Polymorphism in the promoter region sounds like genetic alphabet soup to a lot of people. Break that down for me. What does that actually mean?
Let's unpack that. A polymorphism just means a common variation in a DNA sequence among the population.
Like having different eye colors.
Exactly like that. Now, a gene is basically a set of instructions for building a protein. But genes don't just constantly pump out proteins at maximum capacity all the time.
They need to be regulated.
They do. The promoter region is essentially the volume dial, or the on-off switch, sitting right next to the gene.
Okay.
It dictates how active the gene is and how much protein gets produced.
Okay, so we're talking about a common genetic variation in the volume dial that controls the serotonin transporter.
Yes. Researchers found that people can have a short version or long version of this volume dial.
And does having the short version mean you get depression?
No, not at all. Having the short version doesn't automatically mean you get depression. It's not a deterministic gene like Huntington's disease.
Right.
But epidemiological studies showed that if you have this specific genetic variation, the short allele, and you also experience significant stressful life events.
Like childhood trauma or severe adult adversity?
Exactly. If you have both, your risk of developing major depressive disorder skyrockets compared to someone with the long version who experiences the exact same stressors.
Oh, wow. So it's the interaction between the two. The gene loads the gun and the environment pulls the trigger.
That's a very classic way to describe it, yes.
Yeah.
It perfectly illustrates how biology, mind, and experience interact.
But we have to be cautious with this stuff, right?
Very cautious. While these findings are scientifically illuminating and they help us build models of disease, we are still a long way from a clinical reality where a psychiatrist swabs your cheek.
Sequences your serotonin transporter promoter region.
Right, and then adjusts your therapy based on that specific result.
Mm-hmm.
We require significantly more research before these genetic markers become routinely actionable.
Okay, so we've got a strong conceptual map now. Let's shift gears and look at the actual mechanisms and models.
The mathematical tools we use to measure the forest.
Yes. We need to talk about measures of disease frequency. The term you hear thrown around constantly in the media is prevalence.
Everyone uses that word.
But it's not a monolith, is it? Epidemiologists break it down into 3 distinct types: point prevalence, 1-year prevalence, and lifetime prevalence.
Correct.
Let's start with point prevalence. This is asking, who has the disorder right now, at this exact moment?
Yes.
It sounds really straightforward, but the researchers say it's notoriously difficult, if not impossible, to capture accurately in psychiatry. Why is that?
It comes down to the fundamental nature of psychiatric symptoms. To diagnose a mental disorder, we require multiple specific symptoms to cluster together over a defined period of time. These symptoms are not static. A broken bone is broken 24 hours a day until it heals. But psychiatric symptoms wax and wane. They fluctuate on a daily, sometimes hourly basis.
Right. So someone with major depressive disorder might have a morning where they feel overwhelmingly crushed.
Yes.
But by the evening, they might have a few hours where they feel relatively okay, or at least numb. They still have the disorder, obviously.
Exactly. They still have the illness. So if you conduct a community survey and ask someone, do you meet all these diagnostic criteria exactly at this given second?
You might catch them on a good afternoon.
Precisely. You are going to miss a vast number of active cases because you caught them during a brief fluctuation. Therefore, epidemiologists much prefer to use a 1-month window.
Ah, a 1-month prevalence.
Yes, it captures anyone whose symptoms have clustered together tightly enough to meet the diagnostic criteria at any point within the preceding 30 days.
It smooths out those daily fluctuations.
Exactly. It provides a much more stable, accurate estimate of the current disease burden in a population.
That makes total sense. Then you have 1-year prevalence, which looks at anyone who experienced the disorder at any time within the past 12 months.
Right.
I imagine this is the gold standard metric for healthcare administrators and politicians.
It absolutely is, because healthcare budgets, resource allocations, and hospital staffing models are typically planned on an annual cycle.
Knowing how many people will need services over the course of a year is the most pragmatic data point for running a health system.
Exactly.
And finally, lifetime prevalence. This describes the proportion of a population who have met the criteria for the disorder at any point in their entire lives up to the day they are interviewed.
Yes, ever in their life.
This seems great for studying overarching risk factors, but terrible for service planning, Rainus.
Why do you say that?
Because it counts a single, isolated, depressive episode that happened 40 years ago as a case, even if the person has been perfectly healthy ever since. They don't need a hospital bed today.
That's Spot on. That's the main limitation for health planners. But lifetime prevalence has another massive methodological vulnerability.
Which is?
Recall bias.
Oh, human memory.
Right. As people age, they are simply less likely to accurately remember a brief, perhaps mild episode of psychological distress that occurred decades ago.
Especially when a structured interview is asking them to recall highly specific diagnostic criteria.
Exactly. Like asking someone whether they had early morning awakening or psychomotor agitation for a specific 2-week period in their 20s.
Human memory just isn't that robust.
No, it's not. So lifetime prevalence estimates often undercount the true reality.
So that's prevalence, the total count of existing cases. The other side of the frequency coin is incidence.
Incidence.
And incidence is strictly about new cases occurring within a specified time period.
Right. The crucial distinction between prevalence and incidence lies in the denominator, the population you're analyzing.
How so?
To calculate incidence, you must mathematically remove anyone who already has the disorder from your population pool, because they are no longer at risk of developing it for the first time. You are exclusively looking at the rate of new onset events arising in a population that is currently disease-free.
And because most specific psychiatric disorders are relatively rare in the grand scheme of things, and first incident cases are even rarer, measuring incidence must be an absolute logistical nightmare.
Oh, it is.
You'd need massive population cohorts and years of observation to catch enough new cases to make statistical sense.
It's incredibly expensive and complex. And observing human populations over long periods of time is messy.
People move around.
Right. People are not static data points. They move to different cities. They drop out of the study because they get bored or they pass away from unrelated causes. You don't have a static captive group.
So how does epidemiology handle that shifting sand? If you start a study with 10,000 people and end with 6,000, what's your denominator?
We use a concept called person time at risk.
Person time at risk. Okay.
It's an elegant mathematical solution that acknowledges that populations are non-stationary. Instead of just counting bodies, person 1, person 2, you calculate the actual amount of time each individual person actively contributed to the study.
Before they either developed the disorder, dropped out, or the study concluded.
Exactly.
So if I stay in the study for 5 years, I contribute 5 person years.
Yes.
If you drop out after 1 year, you contribute 1 person year.
Exactly. You sum all those individual time periods up across the thousands of participants to get the total person time.
And that cumulative time becomes your denominator.
Right. It allows you to calculate a precise incidence rate like, say, 5 new cases per 10,000 person years, even when your population is constantly fluctuating.
Okay, here is where we get to the core mathematical relationship that ties all of this together. There is a fundamental equation. Prevalence is roughly equal to incidence multiplied by the duration of the illness.
P equals I times D.
I always visualize this using the bathtub model.
Oh, the bathtub model is perfect.
Imagine a standard bathtub. The water flowing out of the tap represents incidence, the new, fresh cases entering the population.
Right.
The water draining out of the bottom represents people leaving the population of the ill. And that happens through 2 main avenues. They either recover or they die.
So that drain represents your duration.
Yes, the drain is duration.
Yeah.
And the total level of water sitting in the tub at any given moment, that is your prevalence.
The bathtub model perfectly encapsulates the dynamic nature of disease frequency. And internalizing that relationship is vital for clinical reasoning.
Because it highlights how wildly misleading prevalence rates can be if viewed in isolation.
Exactly. If you just look at the water level without understanding the tap and the drain, you can draw disastrously wrong conclusions.
Let's walk through a historical example of that. The classic case the text brings up is HIV/AIDS in the 1990s.
It's the starkest example we have in modern medicine. When highly active antiretroviral therapies were introduced, they were a medical miracle. They were incredibly effective at preventing death. They didn't cure the virus, but they extended the lives of patients dramatically. So, what happened to the duration of the disease?
It skyrocketed. People were suddenly living with HIV for decades instead of succumbing to it within a few years.
Right. Using our model, the drain in the bathtub got plugged up.
Yeah.
Very few people were leaving the population of the ill through death.
The water stopped draining out.
Therefore, even if the incidence, the water flowing from the tap, stayed exactly the same or even decreased due to public health campaigns, the total water level, the prevalence, went up significantly.
Wait, think about how counterintuitive that is for a layperson. If you're a politician or a hospital administrator and you're only looking at a chart of prevalence rates, you see the line shooting upward.
You might panic.
Right. You'd think our prevention programs are failing, the disease is spreading out of control.
But the reality was the exact opposite. That rising prevalence was hard, statistical evidence of a massive medical triumph.
Because our treatments were keeping people alive.
Exactly. It demonstrates beautifully why you must look at incidence, prevalence, and duration in concert to truly understand the dynamics of a disease in a population.
If prevalence goes up, it might mean we are failing. Or it might mean our treatments are working brilliantly. You have to look at the mechanisms.
You do.
Let's move on to another messy reality. Comorbidity. This is a massive issue in clinical psychiatry. Patients rarely present with just one neat textbook diagnosis.
Very rarely. They frequently meet criteria for 2, 3, or more disorders.
Yeah.
We need to distinguish between random and non-random comorbidity.
Okay, random comorbidity first.
Random co-occurrence is just statistical chance. It's the idea that common things are common.
Right.
If disorder A, say generalized anxiety, and disorder B, let's say mild depression, are both very frequent in the general population, some unfortunate people will inevitably suffer from both entirely by coincidence.
There is no shared underlying pathology. It's just the luck of the draw.
Exactly. But non-random comorbidity implies a connection. Non-random comorbidity is what epidemiologists are usually hunting for. This occurs when the prevalence of disorder A is significantly higher in people who already have disorder B than you would expect by chance in the general population.
So that implies a meaningful biological or psychological relationship.
Yes. Perhaps they share common genetic risk factors or shared environmental triggers. Or, more provocatively, perhaps they aren't actually two separate disorders at all.
But rather different clinical presentations of the exact same underlying disease process.
Precisely. But there's a huge trap here that we need to warn our listeners about. We have to be deeply skeptical about artifactual comorbidity.
Artifactual comorbidity, that's when the diagnostic rulebook itself creates an illusion of comorbidity, right?
Yes, it's not a reflection of nature, it's a glitch in our measurement system.
Let's look at the classic example from the older diagnostic manuals regarding antisocial personality disorder and substance use disorder.
Oh, it's a fantastic cautionary tale about how we construct our data. In the era of DSM-3, researchers were analyzing the new criteria and noticed staggeringly high rates of comorbidity between antisocial personality disorder and substance use disorder.
And on the surface, it looked like a profound clinical finding. Like, why were these two seemingly different pathologies so tightly linked?
Right. And what did they find when they looked under the hood?
They realized that the rulebook was rigged.
Yes. Substance use was actually listed as a specific diagnostic symptom for both disorders.
Oh, wow.
The criteria themselves virtually guaranteed that if a patient exhibited significant substance abuse, they were statistically highly likely to tick enough boxes to qualify for the antisocial diagnosis as well, and vice versa.
So the overlap wasn't necessarily a profound biological connection. It was an artifact of how the committees had written the symptom lists.
It was a self-fulfilling statistical prophecy built directly into the manual.
It's a reminder that we aren't measuring fundamental physical constants like the speed of light. We're measuring human constructs.
Very well put.
Okay, let's tackle risk, protection, and causation. We hear the phrase, association does not equal causation constantly in science journalism.
Ad nauseum.
Right. But we rarely discuss why that phrase is so vital. The concept of a confounding variable explains exactly why we can't jump to conclusions.
Confounding is the absolute bane of epidemiological research. It's the ghost in the machine.
The ghost in the machine, I like that.
A confounding variable is a hidden, unmeasured third factor that distorts the relationship between an exposure and an outcome.
How so?
To be a true confounder, it must be independently associated with the outcome you are studying, and it must also be associated with the exposure. But it cannot be an intermediate step on the causal pathway between them.
It creates a mirage. Let's ground this with a concrete example. Say researchers publish a study finding a strong, statistically significant association between smoking cigarettes and suicidal behaviors.
Okay.
The newspaper headline reads, "Smoking causes suicide."
As an epidemiologist, your immediate reaction should be extreme skepticism. You have to ask, what else travels with smoking? And then you introduce alcohol use into the analysis.
Right.
Alcohol use is highly associated with smoking. People who smoke are significantly more likely to drink heavily. Crucially, heavy alcohol use is independently known to increase the risk of suicidal behaviors, entirely regardless of whether the person has ever touched a cigarette.
So the alcohol use is dragging both the smoking rates and the suicide rates upward simultaneously.
Exactly. Alcohol is the confounder. It's muddying the waters. If you just look at smoking and suicide in isolation, you see a strong, alarming link.
But it's an illusion.
Right? Once you use statistical models to mathematically adjust or control for the level of alcohol use, essentially holding the alcohol variable constant across your subjects, you might find that the true isolated effect of smoking on suicide is much smaller than you thought.
Or perhaps it vanishes entirely.
Precisely. Unmeasured confounders can distort findings in any direction, creating false alarms or masking true, dangerous risks.
So whenever you read a paper claiming X is linked to Y, your immediate train thought should be, okay, but what is Z? What invisible factor haven't they measured?
Exactly. What is the Z?
To try and unpick these messy, real-world relationships, researchers use different analytical study designs. The two workhorses we need to understand are cohort studies and case control studies. Let's break down the mechanics. How do they differ fundamentally?
The core difference lies in the direction of time and how you select your starting subjects. Let's start with a cohort study.
Okay.
In a cohort study, you select your subjects based on their exposure status.
Give me a hypothetical scenario for that. Let's say we want to study the link between severe childhood head trauma and the later development of bipolar disorder.
Perfect. In a cohort study, you would recruit a massive group of young children. Some of them have suffered severe head trauma. That's your exposed group.
Right.
The rest have not. That's your unexposed control group. Crucially, at the start of the study, none of these children have bipolar disorder.
Okay, so you start clean.
Then you track them forward over time. You follow them for 10, 20, 30 years, periodically checking in to see who develops the outcome bipolar disorder.
The scientific logic there is incredibly robust. You establish the cause before the effect. You watch the timeline unfold in reality.
Yes.
But earlier you mentioned the logistical nightmares of tracking people. Running a study for 30 years sounds nearly impossible.
It is astronomically expensive and difficult. Because psychiatric disorders, even relatively common ones, only affect a small percentage of the total population. Your initial cohort has to be massive.
Like tens of thousands of people.
Yes, just to ensure enough individuals eventually develop the disorder to give you statistically significant data. And over 30 years, people move, change their names, refuse to answer your calls, or die. The attrition rate can ruin the study.
So what's the alternative when you don't have 30 years and millions of dollars? You run the tape in reverse, a case control study.
Precisely. In a case control study, you select your subjects based on the outcome.
Not the exposure.
Right. You go to clinics and find a group of adults who have already been diagnosed with bipolar disorder. These are your cases. Then you find a demographically matched group of adults who do not have the disorder, your controls.
And then you look backward.
Yes, you look backwards in time, usually through extensive interviews or combing through old medical records to assess their past exposures. You ask both groups, did you suffer a severe head trauma when you were a child?
That is so much faster. You can gather your data in a few months instead of decades. It's incredibly efficient for studying rare disorders.
It is.
But the flaw is obvious, isn't it? You're relying on human memory.
Which brings us right back to recall bias. A patient currently suffering from bipolar disorder, searching for reasons for their illness, might vividly remember and over-report every minor childhood bump to the head.
While a healthy control subject might have forgotten a similar bump entirely.
Exactly. The retrospective nature of case control studies makes them highly vulnerable to distorted data. They are efficient, but you sacrifice the robust timeline of a cohort study.
Okay, let's unpack the next major section of our outline, clinical manifestations. Specifically, we need to focus on measurement and case identification.
This is crucial.
We really have to address the elephant in the room regarding psychiatry as a medical specialty. If I'm an oncologist diagnosing leukemia, I run a blood assay and look for blast cells.
Right.
If I'm an endocrinologist checking for diabetes, I measure HbA1c. They have objective, definitive biological markers. In psychiatry, we do not.
No, we don't.
There are no diagnostic blood tests for schizophrenia, no MRI scans that definitively prove a major depressive episode. We rely entirely on self-report, clinical observation, and patient history.
It is the defining historical challenge of the specialty. Our diagnoses are clinical constructs. We are grouping symptoms together based on observation.
Right.
Because we lack those undeniable biological gold standards, the tools we use to measure and categorize mental illness have to be subjected to intense, rigorous statistical scrutiny.
We can't just trust a doctor's gut feeling.
Absolutely not. We have to constantly ask two foundational questions of our diagnostic instruments. Are they reliable, and are they valid?
Let's separate those two, because people use them interchangeably in casual conversation, but they mean very different things in statistics. Reliability first.
Okay.
This is basically asking about consistency. If two different independent psychiatrists examine the exact same patient using the same diagnostic criteria, will they arrive at the same diagnosis?
That's the essence of reliability. And the statistical tool we use to measure this consistency is called the kappa statistic.
The kappa statistic.
Yes. Kappa is crucial because it doesn't just measure raw overall agreement. It calculates the agreement adjusted for chance.
What do you mean by chance agreement?
Think of it this way. If two psychiatrists are asked to diagnose a very common disorder, or if they just tend to hand out the same diagnosis frequently, they might end up agreeing a lot of the time purely by accident.
Not because the tool is actually good.
Right. Kappa strips that random chance away. It gives you a score between 0 and 1. A score of 0 means the clinicians agree no more often than if they were literally just flipping coins.
And a score of 1.
A score of 1 means perfect, flawless, 100% agreement every single time.
So what's a good score in psychiatric epidemiology?
This is where it gets sobering. In psychiatry, a kappa score between 0.4 and 0.6 is generally considered fair or moderate agreement.
Wait, really?
Yes, and it's often accepted as adequate reliability for a diagnostic instrument.
A 0.4 is adequate. If an orthopedic surgeon agreed with a radiologist on a bone fracture only moderately better than chance, we'd consider that a crisis.
It does sound shocking when you frame it that way.
But it highlights the inherent subjectivity of symptom interpretation, doesn't it? A patient might describe their mood slightly differently to Dr. A than to Dr. B.
Exactly. It's the reality of dealing with human emotion and behavior rather than calcified bone.
So that is reliability. Are we consistent in our application of the rules? But validity is the much harder, more profound question.
Yes, are we actually measuring what we claim to be measuring? Is our construct true?
The epidemiological framework breaks validity down into 3 main types: content validity, criterion validity, and construct validity.
Yes, so let's walk through them. Content validity seems the most straightforward.
It is. Content validity asks, does the measurement tool actually cover all the known established components of the clinical construct?
Give me an example.
If you design a quick 5-question survey to diagnose major depression, but you forget to include any questions assessing anhedonia, the loss of pleasure, or changes in sleep.
Your tool has terrible content validity. It's missing core pieces of the puzzle.
Exactly. Then you have criterion validity. This examines how well your measurement compares to an external benchmark. But we just established we don't have a biological benchmark, so what do we use as the criterion?
Since we don't have a blood test, the accepted gold standard criterion in psychiatric research is usually a comprehensive, semi-structured clinical interview.
Conducted by a human.
Right. Conducted by a highly trained senior expert, which can take hours. If we want to test a new 10-minute screening questionnaire, we compare its results to the exhaustive expert interview.
If the quick questionnaire identifies the same patients as the expert, it has high criterion validity.
Exactly.
And finally, construct validity, which is arguably the most complex and the most important for the legitimacy of psychiatry as a medical field.
It really is the big one.
This is asking how well the diagnosis fits into a broader theoretical understanding of human disease. To explain this, the literature highlights a famous framework developed in 1972 by researchers Robbins and Goose.
Oh, Robbins and Goose. They essentially laid out a roadmap for how psychiatry could prove its diagnoses were real medical illnesses.
The Robbins and Goose criteria represented a monumental existential effort to bring rigorous medical validity to psychiatric categorization.
They argued that you couldn't just group symptoms together and call it a disease. You needed a foundation built on multiple pillars.
What were the pillars?
Well, you need a clear, reliable clinical description of the symptoms and demographic risk factors. You need to look for consistent laboratory or imaging findings.
Even if they aren't diagnostic on their own, they should show a biological difference.
Right. You need clear delimitation from other disorders. The boundaries have to be sharp, so you aren't confusing one illness with another.
And crucially, they argued you need predictable follow-up studies and family studies.
Yes. The natural history of the disorder should be consistent over time. If you diagnose someone with a specific condition today, it shouldn't randomly morph into a completely unrelated cluster of symptoms 5 years from now.
That makes perfect sense.
And Through family studies, you need to demonstrate an increased prevalence of the same disorder among close relatives, which suggests a genetic or shared environmental etiology.
Establishing true construct validity across all those domains takes decades of cumulative, painstaking research.
It does. It's a massive undertaking.
This intense focus on reliability and validity wasn't just an abstract academic exercise. It was born out of a genuine, highly publicized crisis in the field of psychiatry in the mid-20th century.
Yes, it was a very tense time for the profession.
To really understand modern epidemiology, we have to look at the historical narrative of the Diagnostic and Statistical Manual of Mental Disorders, the DSM, and specifically, we need to talk about the legendary US-UK study.
Ah, yes. This is essentially a historical drama for epidemiologists.
What exactly happened?
It's a phenomenal piece of medical history that forced the entire field to look in the mirror. In the 1960s, using the early psychoanalytically heavily influenced editions of the DSM, epidemiologists noticed a massive, glaring disparity.
What kind of disparity?
In the United States, patients admitted to psychiatric hospitals were being diagnosed with schizophrenia at incredibly high rates. It seemed like an epidemic.
Okay.
Meanwhile, in the United Kingdom, patients with seemingly very similar clinical presentations were overwhelmingly being diagnosed with affective disorders, like manic depression.
So the epidemiological map showed two wildly different realities. The ultimate question was, is the territory actually different, or is the map just wrong?
Right. Were Americans biologically or environmentally more prone to schizophrenia, or were the doctors themselves the variable?
The implications were huge. So researchers launched the US-UK Diagnostic project.
How did they test it?
They took a group of experienced psychiatrists from both countries, but they didn't let them use their standard local diagnostic habits. Instead, they trained them all to use a newly developed, highly standardized, rigorous diagnostic instrument called the Present State Examination, or PSE.
Okay.
The PSE forced the doctors to ask specific questions and rate specific symptoms according to strict rules, rather than relying on their own loosely defined clinical judgments or local hospital traditions.
And what happened when they used the PSE on the same cohorts of patients?
The transatlantic differences completely vanished.
Wow. The epidemic disappeared.
Completely. The American psychiatrist and the British psychiatrist, when forced to use the same standardized tool, suddenly agreed on the diagnoses.
So it was just a difference in diagnostic culture.
Yes, it proved unequivocally that the apparent massive population differences were entirely an artifact of diagnostic bias. American doctors simply had a much broader, looser, more expansive definition of what constituted schizophrenia.
While British doctors had a broader definition of affective disorders.
It was a crisis of reliability. The doctors weren't speaking the same language.
It was undeniable proof that the early DSMs, which relied on vague, narrative descriptions of diseases, were failing. You couldn't trust the epidemiological data because you couldn't trust the diagnostic consistency.
And this crisis led directly to a revolution in the field. The publication of DSM-3 in 1980.
The game changer.
Yes, DSM-3 changed the paradigm entirely. It threw out the vague glossaries and introduced strict, symptom-based, operationalized criteria.
You no longer just felt the patient was depressed.
Right. You had to document that they had symptom A, plus at least 3 of symptom B, persisting for a continuous duration of C weeks. It gave every psychiatrist in the world a common, testable language.
And that common language is what finally made large-scale, modern psychiatric epidemiology possible.
Exactly. You cannot count what you cannot reliably define. DSM-3 finally provided the rigid definitions required for scientific counting.
This brings us perfectly into the integration and clinical reasoning section of our deep dive, focusing on the era of major epidemiologic surveys.
Right.
Once DSM-3 provided the tools, the National Institute of Mental Health launched a massive, unprecedented project in the 1980s, the Epidemiologic Catchment Area, or ECA, program.
This was groundbreaking.
The ECA was a watershed moment. It involved sending trained lay interviewers out into the community to interview roughly 20,000 people across 5 U.S. sites.
And the data it produced fundamentally shocked the clinical establishment.
Why? What did they find that was so surprising?
Well, before the ECA, because of Bergson's bias, it was assumed that many specific disorders, like obsessive-compulsive disorder or social phobia, were vanishingly rare.
Because very few people showed up in specialist inpatient clinics with those complaints.
Exactly. But the ECA went into people's living rooms and discovered that these disorders were actually highly prevalent. People were just suffering in silence, completely untreated, because their symptoms didn't land them in an A&E.
It uncovered a massive hidden iceberg of morbidity.
It did. The ECA also revealed that the onset of many severe adult disorders actually originated in childhood or adolescence.
Which overturned the prevailing wisdom of the time.
Right, which assumed that children were largely protected from severe psychiatric illness. The sheer volume of untreated disabling mental illness uncovered by the ECA provided the hard, undeniable statistical data needed to begin fighting for mental health insurance parity with physical health conditions.
It proved, beyond a doubt, that mental illness was a massive, unaddressed public health crisis.
Then, in the 1990s, they followed up with an even more ambitious project, the National Comorbidity Survey, or NCS. This was a nationally representative household survey.
Okay.
But here is where we get some serious pushback and intense debate, and this loops right back to the hook we opened the show with.
Right, the disappearing pins on the map.
Yes. When the NCS published its initial results, the prevalence rates for mental disorders were noticeably alarmingly higher than what the ECA had found just a decade earlier.
So the obvious question the media asked was, is society suddenly getting much sicker? Or did the researchers mess up the measurement?
It sparked intense scientific scrutiny. While there were some minor demographic and methodological differences between the two massive surveys, the critical factor turned out to be how they handled that philosophical concept we discussed earlier, clinical significance.
So what caused the diagnosis?
Precisely. In psychiatry, it is not enough to simply tick the boxes for a list of symptoms. The modern DSM requires that those symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning.
Give me an example of that.
Well, you might have a phobia of snakes, but if you live in a high-rise apartment in Manhattan and never encounter a snake, it doesn't impair your life. It shouldn't count as a clinical disorder.
So how did the surveys handle that impairment clause?
The early ECA analyses had inconsistently applied this distress and impairment criterion when crunching the numbers. The initial headline data from the NCS had also not strictly factored it in.
Oh, I see.
When researchers went back to the raw data and rigorously reanalyzed both data sets, requiring strict evidence of clinical significance, meaning the interviewer documented that the symptoms genuinely impaired the person's daily life, the prevalence estimates dropped dramatically.
The NCS estimates plummeted by roughly a third. Millions of statistical cases wiped off the map.
And once adjusted for clinical significance, the rates from the two massive surveys aligned much more closely. It wasn't that society was rapidly deteriorating. It was an artifact of exactly where the diagnostic line was drawn.
That is a staggering takeaway for clinical reasoning. Tweaking the definition of what constitutes a case sense, just insisting on functional impairment, changes the entire epidemiological landscape.
It shows how incredibly sensitive these population counts are to the exact wording of our criteria.
It reminds us that epidemiology is not just about blindly counting numbers. It's about deeply understanding the rules, assumptions, and human constructs that generate those numbers.
Moving from the national surveys to the global stage, we have to look at the Global Burden of Disease Study, the GBD, and the World Mental Health Initiative. How do epidemiologists even begin to measure the burden of disease across the entire planet?
It's a huge challenge. How do you compare the impact of malaria in one country to schizophrenia in another?
Right.
The GBD studies introduced a revolutionary unifying metric called disability-adjusted life years, or DALYs. Before the GBD, global public health mostly just counted deaths. Mortality was the ultimate metric.
If a disease didn't kill you, it wasn't considered a massive priority for international funding.
Exactly. DALYs changed that paradigm completely. One DALY essentially equals 1 year of healthy life lost.
And it's calculated by combining two different types of loss, right?
Correct. It adds two components together. Years of life lost to premature death, or YLL, and years lived with a disability, or YLD. So it combines mortality and morbidity into one single universal currency of human suffering.
And when you calculate disease burden using DALYs, the impact of psychiatric disorders suddenly becomes impossible to ignore.
It's a revelation. According to recent GBD data, mental disorders account for roughly 5% of the total global disease burden across all medical specialties. And crucially, almost all of that burden is driven by YLD years, lived with a disability. Psychiatric disorders may not be the leading cause of premature death compared to cardiovascular disease or metastatic cancer, but they are absolutely leading drivers of chronic, lifelong disability.
Depressive disorders and anxiety disorders sit right at the very top of that list globally, keeping millions of people out of the workforce and impairing their quality of life for decades.
That reframes the entire public health mission of psychiatry. We aren't just preventing death, we are fighting a massive battle against chronic, debilitating disability.
But applying these surveys globally raises a huge red flag regarding cultural differences. When you take a highly structured diagnostic interview based on the DSM, translate it into 50 different languages, and administer it in profoundly different cultures, do you really capture the clinical truth?
It is a massive, highly contentious area of ongoing debate. The World Mental Health Surveys found wildly different prevalence rates for disorders across different countries.
Now, some of that might be true variation in environmental risk factors or genetics.
But a huge confounding factor is what medical anthropologists call idioms of distress.
Idioms of distress, meaning how different cultures express their suffering.
Exactly. Different cultures conceptualize, experience, and express mental suffering in profoundly different ways.
Wow.
If a Western-designed diagnostic tool relies heavily on psychological self-reflection, asking, "Do you feel a pervasive sense of worthlessness?" it might completely miss a severe depressive episode in a culture where distress is primarily experienced and expressed through somatic physical complaints.
Like someone reporting chronic, unexplained chest pain or the concept of brain fag in certain West African cultures, instead of reporting, "I feel sad."
Precisely. If the survey doesn't ask about those specific physical manifestations, it will undercount the depression in that population. The validity of translating highly specific, culturally bound criteria across deep linguistic and cultural divides remains a significant, unresolved challenge in global epidemiology.
Before we wrap up our main discussion, we have to touch on an incredible, real-time epidemiological event that we all lived through, the COVID-19 pandemic.
Oh, yes. From an epidemiological standpoint, it served as a massive, unplanned global stress test. What did the data actually show us about population mental health? The preliminary epidemiological data largely confirmed what clinicians saw on the ground in their emergency rooms. Unprecedented social distancing, quarantine protocols, economic terror, and the disruption of daily routines acted as a profound, universal environmental exposure.
Right.
Massive meta-analyses showed substantial statistically documented increases in the prevalence and overall burden of major depressive disorder, anxiety disorders, and a significant, alarming worsening of eating disorder psychopathology.
We saw rising rates of systemic burnout, post-traumatic stress, and interpersonal violence.
But epidemiology isn't just about cataloging risk and disaster. It also identifies protection. When you have a global exposure like that, you also find out who is resilient.
What factors mitigated the psychological damage?
That is the crucial clinical takeaway for the future.
Hmm.
The population studies identified several strong, modifiable protective factors during the lockdowns. Individuals who actively maintained structured daily routines, engaged in low screen time, actively limited their doom scrolling and consumption of pandemic-related news, and spent time in nature showed significantly better mental health outcomes, even controlling for other factors.
So it's not just interesting data, it gives clinicians concrete, evidence-based lifestyle interventions to recommend during periods of acute population-wide stress.
Exactly.
Okay, let's crystallize everything we've covered into our key takeaways. Epidemiology fundamentally shifts our focus from the individual tree to the distribution and determinants of illness across the entire forest. We learned that incidence, the new cases, and prevalence, the total current cases, are mathematically linked by the duration of the illness, the bathtub model. We discussed how psychiatric measurement is incredibly complex, relying on the evolution of rigid criteria like DSM-3 to achieve reliability, as demonstrated by resolving the US-UK diagnostic divide. We established that association is not causation, and understanding confounding variables like alcohol use in smoking studies is critical to avoid drawing false conclusions.
Spot on.
And finally, the global burden of mental illness is massive, primarily driven by years norms. Lived with a disability, highlighting psychiatry's vital, undeniable role in global public health.
A very comprehensive summary of the foundational concepts.
Before we sign off, let's solidify these concepts with a few quick clinical reasoning questions to test our listeners. I will ask the question, give you a moment to pause and think, and then our expert will break down the answer. Are you ready?
Ready when you are.
Question 1. A new, highly effective treatment for a chronic psychiatric disorder prevents death but does not cure the underlying condition. What will happen to the incidence and prevalence of this disorder in the population?
Pause and think about the bathtub model. The incidence, the rate of new cases flowing from the tap remains the same because the treatment doesn't cure or prevent the disease from occurring in the first place. However, because the treatment prevents death, The duration of the illness increases. The drain at the bottom of the tub is plugged. Therefore, the total water level, the overall prevalence of the disorder in the population, will actually increase.
Excellent. Question 2. In a hospital setting, researchers note a strong statistical association between disorder A and disorder B. However, when they conduct a massive community survey outside the hospital, this association is found to be much weaker. What epidemiologic concept best explains this discrepancy?
This is a classic demonstration of Bergson's bias. Individuals who suffer from multiple comorbid conditions, having both disorder A and disorder B simultaneously, are significantly more likely to seek treatment and be hospitalized than those suffering from only one disorder. Therefore, clinical samples artificially inflate the apparent association between the two conditions compared to the true lower rate of co-occurrence in the general community.
Spot on. Question 3. A study finds that high coffee consumption is statistically linked to severe anxiety. However, further analysis shows that the heavy coffee drinkers in the study also consistently sleep less than 4 hours a night, and lack of sleep independently causes anxiety regardless of coffee intake. In this scenario, what is the lack of sleep considered?
The lack of sleep is a confounding variable. It is independently associated with both the exposure drinking coffee and the outcome severe anxiety. It creates a false or exaggerated impression that coffee is the primary cause, muddying the true relationship. You must mathematically adjust for sleep in your statistical model to understand the true, isolated effect of the caffeine.
Question 4. What was the primary field-changing finding of the landmark US-UK study regarding the diagnosis of schizophrenia and affective disorders?
The study revealed that the massive apparent disparities in prevalence, extremely high schizophrenia in the US and high affective disorders in the UK, were not actual biological differences in the populations. They were entirely an artifact due to variations in the diagnostic habits and loose criteria used by clinicians in the two countries. When a standardized instrument, the present state examination, was used, the differences vanished. This realization directly catalyzed the development of the rigorous, symptom-based criteria of DSM-3.
Question 5. Which specific component of the global burden of disease metric primarily drives the incredibly high global burden associated with psychiatric disorders?
It is driven overwhelmingly by YLD years lived with a disability. Unlike many other major disease categories that drive high years of life lost to premature death, the massive societal impact of psychiatric illness comes from the chronic, long-term functional impairment it inflicts on populations over the course of decades.
And the final question, question 6. In a study, researchers select a group of individuals who have already been diagnosed with major depressive disorder and a control group without the disorder. They then look back at their childhood medical and social records to assess their past exposure to trauma. What type of study design is this?
Because the researchers are selecting participants based on the presence or absence of the outcome, the depression, and then looking backwards in time to assess past exposure, the trauma, this is a case control study.
Yeah.
It's efficient but highly vulnerable to recall bias.
Brilliant. We've covered a massive amount of ground today, mapping the forest of psychiatric epidemiology. But to leave you with a final provocative thought, our entire discussion today has been predicated on counting cases-discrete categorical diagnoses defined by the DSM. You either have the disorder or you don't. But the cutting edge of the field is currently shifting. Researchers are moving towards dimensional models like the NAMH's Research Domain Criteria or RDOC, which look at neurobiology and behavior not as neat, separate boxes, but as continuous, overlapping spectrums. If we eventually abandon strict categories, how will our maps of the forest change? Will future epidemiologists stop counting cases entirely and instead start measuring population-wide spectrums of human experience? It's a paradigm shift that will redefine everything we've discussed today. Here are the details of this episode.
Epidemiology in Psychiatry. Byline. To understand mental illness at scale, we must move from individual stories to population patterns. Episode description. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. How common are disorders, who is affected, and what factors influence risk and outcome? Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. This chapter introduces the foundational concepts of psychiatric epidemiology, including incidence, prevalence, risk factors, and protective factors. It emphasizes that mental disorders are not randomly distributed. They follow patterns shaped by biology, environment, social context, and time. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. A key theme is measurement. Defining and identifying psychiatric disorders in populations is inherently complex. Diagnostic criteria, cultural variation, reporting bias, and study design all influence what is observed. Epidemiology is therefore not simply about counting cases, but about understanding how those counts are constructed. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. The chapter also explores causal inference. Associations between variables do not necessarily imply causation. Epidemiology uses study designs such as cohort, case control, and cross-sectional studies to move closer to understanding causal relationships while recognizing inherent limitations. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Clinically, at a systems level, epidemiology informs prevention, service planning, and policy. It identifies high-risk groups, tracks trends over time, and evaluates interventions. It transforms psychiatry from a purely clinical discipline into a public health enterprise. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Ultimately, this chapter reframes mental illness as both an individual experience and a population phenomenon requiring both clinical insight and epidemiological thinking. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Key takeaways. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Epidemiology studies the distribution and determinants of mental disorders in populations. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Incidence and prevalence are key measures of disease frequency. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Mental disorders follow patterns influenced by biological, social, and environmental factors. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Measurement in psychiatry is complex and influenced by diagnostic and cultural factors. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Association does not equal causation. Study design is critical. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Epidemiology informs prevention, policy, and service planning. Epidemiology provides the lens through which psychiatry steps back and examines mental illness at the level of populations. Rather than focusing on individual cases, it asks broader questions. Psychiatry operates at both individual and population levels.